Big news, CardioNerds! AHA Scientific Sessions 2025 is now 4 full days. Get more late-breaking science, immersive learning, and meaningful connections. Don't miss core cardiology programming, 21 education communities, and guideline-focused sessions. November 7th through 10th in New Orleans. Register now at scientificsessions.org.
The American Heart Association Genomic and Precision Medicine Council kindly invites you to attend our upcoming full-day symposium on November 7th at the Scientific Sessions. Learn from distinguished experts about the cutting-edge advances in genetic medicine that will transform the future of your patient care.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio-nerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, CardioNerds. This is Gurleen Kaur, Cardiology Fellow at Brigham and Women's Hospital. We're here today with a very special episode on Cardio-Obstetrics as part of our collaboration series with the American Heart Association Women in Cardiology Committee. I'm here with Dr. Anna Radhakrishnan, Cardiology Fellow at Mount Sinai Hospital. Anna, I'll turn it over to you to start introducing our fantastic panel of experts tonight.
Thanks, Gurleen. Today we are joined by Dr. Rina Mauricio, who is an assistant professor at UT Southwestern Medical Center, where she is the director of women's cardiovascular health and director of cardio-obstetrics. She specializes in echocardiography, preventive cardiology, and women's cardiovascular health. She did all of her advanced training in cardiology and cardiovascular imaging at UT Southwestern, where she also served as a chief fellow. She is a leader in the field of cardio-obstetrics and first author on the 2025 AHA scientific statement on addressing CV and obstetric risks in patients undergoing assisted reproductive technology. Thank you for being here today, Dr. Mauricio. Next, we are joined by Dr. Afshan Hameed. Dr. Hameed is the division director of maternal fetal medicine and leads the cardio-obstetrics program at UC Irvine. She is a board-certified cardiologist and maternal fetal medicine specialist. She is a nationally recognized expert with clinical and research interests in improving maternal mortality, heart disease, and anticoagulation in pregnancy. She also co-authored the book Cardio-Obstetrics, A Practical Guide to Care for Pregnant Cardiac Patients, the ACOG Practice Bulletin on Heart Disease and Pregnancy, the ACOG Interconception Guidelines, and she also serves on the California Maternal Quality Care Collaborative Pregnancy-Associated Mortality Review Advisory Committee. Welcome to you both, and thank you so much for being here today.
Thanks, Anna. Thanks for having us.
Next, we have Dr. Doreen DeFaria Yeh, who's currently serving as the Program Director of the MGH Cardiovascular Disease Fellowship Program and Co-Director of the MGH Cardiovascular Disease and Pregnancy Program. She's an Associate Professor of Medicine at Harvard Medical School. Her clinical focus includes ACHD and high-risk cardiac conditions in pregnancy, as well as echocardiography with expertise in ACHD echo. He's pioneered a number of important initiatives to innovate in education and cardiovascular training, and is a recipient of numerous teaching and mentoring awards. And we're also lucky to be joined by a fourth faculty expert today, Dr. Garima Sharma, who is the Director of Women's Cardiovascular Health, Director of Cardio-Obstetrics, and Director of Preventive Cardiology at Inova. Her clinical and research interests include preeclampsia, postpartum prevention of complications from hypertensive disorders of pregnancy, SCAD, and cardiovascular health in women and gender inequities. She is a national leader in women's health and has served as an author on several AHA scientific statements related to cardio-OB, and is also the founder of the cardio-OB program at Hopkins. Welcome, Dr. DeFaria and Dr. Sharma.
It's a pleasure to be here. Thank you.
Thanks so much for having us.
So we're really lucky to be joined by 4 experts in cardio-OB tonight, and really excited to learn from your expertise and insights on this evolving field. We know that cardio-obstetrics or cardio-OB is a field that really sits at the intersection of 2 high-stakes disciplines, and that's cardiology and obstetrics. And we know that cardiovascular disease is the leading cause of maternal mortality in the US, and that this burden is then equally shared. The field of cardio-OB really came out of the need for multidisciplinary care, thoughtful risk stratification, and long-term advocacy for women with or at risk for cardiac conditions during pregnancy. And today we're really honored to be joined by some of the leaders within the field.
So let's start with the basics. Dr. Mauricio, can you tell our listeners what exactly is cardio-obstetrics, and why was it necessary to define this as a distinct field?
Thanks, Anna. Yeah, that's a great question and really a nice starting point for us this evening. So, as it's been previously stated, cardio-obstetrics is the intersection of cardiology and obstetrics. That's very obvious. I think that most people think about it first and primarily as taking care of women during pregnancy, which it is. So we take care of patients who have pre-existing cardiovascular conditions from complex congenital heart lesions to prior history of MI, valvular heart disease, depressed EF, and take them through pregnancy and ensure that they have as safe and healthy a pregnancy as possible. But I think it's also important to know that cardio-obstetrics extends to the time before pregnancy and after pregnancy. So to start with preconception counseling, this field is really important. When you have a patient who has pre-existing cardiovascular disease, talking to them about the importance of pregnancy planning, contraception, and if they do choose to pursue a pregnancy, what would be the safest way to do so? And if they choose to pursue something like assisted reproductive technology, whether it would be safe for them to carry the pregnancy or to use surrogacy. So one, there's preconception planning. And two, something that we refer to in cardio-OB as the fourth trimester, which is that time after pregnancy that's also super important for this patient population. And that is getting patients back on cardiac therapy that maybe was contraindicated during pregnancy because of teratogenicity, or even, this is now, I think, really increasingly recognized, those patients who have adverse pregnancy outcomes that increases their future risk of atherosclerotic cardiovascular disease, making sure that we plug them into cardiology for a primary prevention visit. So that's that fourth trimester time period. And I think it's really necessary to define this field because this is a complex group of patients and they really require a lot of multidisciplinary care to get them, counsel them prior to pregnancy, through pregnancy, and afterwards. So I'm really excited that it's now being really recognized as a true and distinct field in and of itself.
Thanks for walking us through that, Dr. Mauricio, especially the point that it's not just about taking care of pregnant patients, but preconception as well as postpartum care. And Dr. Hameed, you bring a really unique perspective to the table as both a cardiologist and a maternal fetal medicine physician. I remember when I was a third-year medical student and rotated on OB and had the opportunity to do a few weeks of MFM, and I just found it really fascinating to think about the physiology and the complexities of care. And MFM really plays an important role in the care of these patients with cardiac conditions in close collaboration with cardiologists. So, can you tell us, our listeners, a little bit more about what's changed in the past decade that's brought cardio OB to the forefront? What major shifts have you seen from both the cardiology and the MFM perspective in how we care for patients with cardiac risk factors in pregnancy?
Thank you, Gurleen. First, I would like to thank you for inviting me back, and it's a pleasure to be here today. Let me briefly take you back 2 decades. This was the time when cardiologists were not interested in OB patients. None of the cardiology fellows wanted to see a pregnant patient, and obstetricians likewise. No cardiac patients allowed in their offices. We were working in silos, and that reflected in maternal outcomes. It wasn't until maternal mortality reviews that informed us that cardiovascular disease is the number one cause of non-obstetric maternal mortality. Not only that, in a prototype mortality review, the most disturbing element that we found was that mothers had presented with significant cardiac symptoms that were often dismissed as being part of normal pregnancy. And equally important was the patient's knowledge gaps in when to seek medical care. We also learned that we as healthcare system do very well taking care of patients with pre-existing or known cardiovascular disease. We live in this era of modern medicine, well equipped to care for the highest risk patients. However, we need to identify patients early. And a large proportion of adverse outcomes related to cardiovascular disease and in patients who add to maternal mortality are the ones who do not have a prior diagnosis, or they were not even diagnosed with cardiovascular disease in pregnancy until after the fact. So the challenge really for us is early recognition to make a change in the ultimate maternal outcomes. So coming back to the recent change in the last decade, it's truly refreshing to witness the evolving field of cardio-obstetrics. Recognized formally, as you know, by the American College of Cardiology a couple years ago, and literature on pregnancy and heart disease has exploded in the last decade. I am most excited to see the trainees, both cardiology and maternal fetal medicine, who are seeking knowledge and expertise in the field of cardio-OB. They are the future healthcare providers. They are rooted in the collaborative multi-D care for this high-risk population. From our perspective, our cardio-OB team at UCI is working on creating a standardized measure on cardiovascular risk assessment in pregnancy. And my professional goal is to have all pregnant patients be screened for cardiovascular disease as part of their routine prenatal care. And I believe the impact is twofold. One, we identify patients with underlying cardiovascular disease. A lot of times a patient underwent a cardiac surgery when they were a toddler and they forgot about it. And when you bring up cardiac disease and we talk about it during pregnancy, we have identified uncovered, undiagnosed congenital heart disease. We also, in this process, identify cardiovascular risk factors to educate these patients to improve future cardiovascular health. And of course, as brought up by Dr. Mauricio earlier, one of the challenges is continuity of care after pregnancy and postpartum, the fourth trimester. As this field of cardio-OB solidifies, patients with underlying cardiovascular risk factors and adverse pregnancy outcomes should be followed long-term to prevent complications. And I see that in future.
Thanks so much for giving us that historical context and walking us through the evolution of the field. It's clearly so very exciting, and I think there's only so much more to do in terms of interdisciplinary care for these patients. Dr. DeFaria, from your perspective, cardio-obstetrics isn't new to the congenital world. ACHD physicians have been taking care of women of childbearing age with or at risk for cardiovascular disease even before cardio-OB became a distinct field. From your perspective, how has ACHD care shaped your approach to managing pregnant patients with complex cardiovascular disease?
Well, thank you so much for the question. It's a great honor to be on today with such fantastic experts in the field. So thank you for opening this conversation. So certainly within the field of ACHD, caring for pregnant patients is really central to the work that we do. The field of adult congenital heart disease really began decades ago in the 1960s, early 1970s, when the children who were the recipients of new technology in congenital heart surgery and anesthesia and advances in, pediatric perioperative care really were seeing the benefits of longevity. There was a population of adult patients that really hadn't survived previously. And with that, experts in that field recognized that an important part of their care for these adult patients, this new population of patients, was family planning and pregnancy. And interestingly, many years ago, often the advice may be, avoid pregnancy because we don't know what the risks may be. And certainly, it must be dangerous. I think we've learned a tremendous amount over the decades about congenital heart disease and the impacts of pregnancy, and have really allowed our field to feel more comfortable in managing patients with even the most complex congenital heart conditions safely through pregnancy and in the postpartum period. So this care is really truly embedded in all that we do in the longitudinal care of people born with cardiac disease and really, in this field of young patient cardiology. Our congenital heart patients, both in and out of pregnancy, carry a very high burden of comorbidities. They have a lot of arrhythmias. They have a lot of valve disease. They develop cardiomyopathies. They have pulmonary hypertension and aortopathy, and often are anticoagulated. And often patients may have multiple of these comorbidities. And these all are things we know in isolation in a normal heart pose risk during pregnancy. But the challenge, and often, the wonderful and fun parts of this field, is managing those individual comorbidities or the constellation of comorbidities in a patient who has underlying abnormal anatomy and unusual hemodynamics and maybe also cyanosis. And so it is so critical for ACHD experts to be very nuanced in their understanding of all of these different aspects of cardiac issues that can pose problems in pregnancy. Because not only do we have to feel comfortable managing in a normal heart, but also in people with abnormal underlying hearts. So we've had to ensure that training in congenital heart disease really maintains a lot of experience, repetition, and focus on the management of pregnant patients. Of course, as Dr. Hameed said, however, though, patients who have a new diagnosis of cardiac disease during pregnancy or in that postpartum period often pose the greatest risk for morbidity and mortality. Certainly, we have a shortage of adult congenital heart disease, physicians, and there's absolutely no way that our community alone can care for all of the women who need expert cardiac care during pregnancy. It truly is an important collaboration that we have in the ACHD field with all of our collaborating cardiologists and women's heart health experts to ensure that we can care for women and identify these conditions at a time when they may show up in the emergency room when whoever, is on call or any cardiologist is on call. So we have a tremendous responsibility to ensure that we're educating our next generation of cardiologists really very comprehensively about cardiac conditions in pregnancy so that all cardiologists feel equipped to manage these situations when they come up.
Thank you for sharing those insights with us, Dr. DeFaria. It's so fascinating to hear about the history and how the field has evolved over time. And I can hear the passion you have for the field and the way you describe the complexities and nuances in the care of these patients. And Dr. Sharma, now we'll turn it over to you to hear your insights. And also wanted to mention to all our listeners that I've learned so much from your prior episode on CardioNerds on normal pregnancy physiology. And so everyone should definitely go back and give that episode number 111, a listen. And Dr. Sharma, you're on the ground managing a variety of cardiac conditions during pregnancy. What does contemporary cardio-OB care look like for you?
Absolutely. Thank you for that shout out. And definitely one of the blast from the past and an important sort of baseline for people to review. So thank you. This is a really important question. The contemporary field of cardio-OB is complex, is multidisciplinary. It has several layers, and it has aspects of both inpatient and outpatient care. And so I think I want people to understand that it's a scalable contemporary cardio-OB management, and it really depends on which part of the health system you are in. And I also want folks to understand that it's not really that one size fits all, because an example of this, if you're looking at cardiovascular risk stratification or risk assessment during pregnancy, those risk scores are primarily derived out of cohorts that are not based in the United States. So we have to really be able to individualize care according to the patients that we see. Having said that, they do allow us to have a roadmap of how to address, optimize, predict, and prevent risk and cardiovascular decompensation during pregnancy. But then there are several other diseases and disease processes that do not fit into that traditional realm of cardiovascular risk scoring, such as Sahara, CARPREG, and the modified WHO. And so for those, we have to really have a shared decision-making process between the patient, between the MFM, between the multidisciplinary team members, including nurse practitioners, pharmacists, nurse navigators, anesthesia, genetics, and coming up with a very comprehensive way to address and assess these risks. Also, something to mention is that there are evolving disease processes that now we're starting to recognize have significant burden, as several of my various team colleagues already mentioned. What do you do with patients who establish themselves at higher risk during pregnancy that previously we didn't know about? We really don't have a good way of addressing and assessing those risks, because when we put them into our pool cohort equations or even prevent equations, it doesn't really modify their risk a whole lot. So, we really have to dig down and say, what is your individual risk and how can we really help manage you long term so that we can prevent future atherosclerotic cardiovascular disease or risk. So the salient features here to recognize are, number one, contemporary cardio-OB care is multidisciplinary. It's true multidisciplinary. And there are several members in this team: cardiologists, pharmacists, OBGYNs, MFMs, fertility doctors, and reproductive endocrinologists, and many others that are involved as the disease changes and it's different from patients to patients. Second, patient and the family are at the center of this multidisciplinary care, and what they wish and what their own risks or assessments are and what their understanding of their disease is extremely important. Number three, recognizing that this is a part of their overall continuum of care and it's not a one-time episode in their life, I think is important, as already mentioned, many others on here. And also, fourth is, how do you actually create programs that are scalable? Because one size does not fit all, and what can work in your health system probably doesn't apply to something else. So thinking about how you can scale your contemporary care to geographical location that you practice in is important.
Dr. Sharma, thanks for sharing your thoughts and expertise with us and the key points that cardio-OB is truly a multidisciplinary team effort, as well as the importance of patient-centric decision-making. When I've had the opportunity to work with cardio-OB physicians in the clinic, I'm always impressed by the way that they counsel patients and also really remember that the patient is at the center, and it's really essential to listen to their voice and concerns and how to kind of put that all into the contextualized care and management that will be kind of the next steps. And it's been great to hear from all of you about how the field of cardio-OB has really grown and evolved and the collaboration that happens in the field. So now we want to turn into discussing another important aspect of cardio-OB, and that's the role of advocacy in improving patient care. We know that healthcare access can be a barrier for our patients at multiple levels, and it's especially true in rural settings where labor and delivery units are closing and there might be other barriers. So, Dr. Hameed, how does this affect your patients, and how do we mitigate these risks when we're thinking about healthcare access?
Thank you, Gurleen, for bringing up this very important aspect of patient care to this forum. In general, the role of telemedicine cannot be overemphasized. One of the good things that came out of COVID pandemic was use of telemedicine, and we are all so thankful for that piece of it. More importantly, as I mentioned earlier, we need to know if the patient has cardiovascular disease. So the importance of risk assessment, the stratification, so that you could potentially transfer that patient out of that rural setting to a larger center where she can be cared for is crucial in these situations. Additionally, I think the patient education and healthcare provider index of suspicion in a pregnant patient when she's presenting with cardiovascular symptoms is super important. Now, I think even though I am speaking from California, and California is a relatively high-resourced state, we have over 250 maternity units. And I can tell you that even in this setting, not all have immediate access to a cardiologist, for example, or cardiology services. So we have a system in place where once a patient is identified having a significant cardiac issue, that these patients are transported to a higher level of care to the regional perinatal centers. And when we look at the broader aspect throughout the country, and especially in areas of maternity deserts, this issue is amplified way more than it exists in California. There are some ways. One of them I mentioned is telemedicine, but I was really impressed by the work that they're doing in the state of Georgia. I had the opportunity to be there as part of their initiative for improving maternal mortality, and they are using doula services. They have implemented cardiovascular risk assessment tool that was created as part of our work with the California Maternal Quality Care Collaborative. And they have a paper version where doulas go visit these patients after they deliver. And that particular time last year when I was over in Georgia, they were telling me that there were at least 2 patients who in rural areas were screen positive with shortness of breath who were brought back into the healthcare system, and they were diagnosed with peripartum cardiomyopathy. So there are ways to bridge that gap where patients don't have direct access, but it needs to be in a structured format where you have enough patient education and you have education in that area in the primary healthcare setting. What are the high-risk features in a pregnant or postpartum patients that may predispose them to a higher risk or the need for transport? And then the other big piece, as we all have heard and still have issues, is the pregnancy options counseling. We know that there are certain cardiac diagnoses where the maternal risk or the mortality risk is so high that you would offer them pregnancy termination. So again, unless we know about those situations, we can't really help them. So that is another piece of information. And my advice really is, in each care setting, wherever a maternity patient can arrive, there should be a system in place how to triage them. And whether it's through telemedicine or access to the regional perinatal center, it's very important to have these patients sent to a place where they are taken care of in a safe manner.
Thank you, Dr. Hameed. I think that was really important and exciting to hear, of course, the initiatives that have already taken place or are in the works, but also I think importantly to hear about the opportunities that we have as a field and, as a country and honestly world at large to really improve the care of these patients in particular. Dr. Mauricio, turning it over to you. Advocacy, as we've mentioned again and again, is such an integral part of cardio-obstetrics, especially as we work to address this really alarming maternal health disparities in this country. In your view, how can cardiologists, both those in training and in practice, play a more proactive role in supporting women before, during, and after pregnancy?
Thanks, Anna. That's such an important question. And definitely advocacy is such an important part of cardio obstetrics. I think to kind of contextualize the importance of this question, I think we have to go back to what Dr. Hameed had said at the beginning of this episode, which is that cardiology and obstetrics used to live in silos. And it is honestly fairly recently that we have sort of started to blend the worlds where appropriate. And I think that, when we think about how we as cardiologists can play a more active role in this patient population, is kind of recognizing the fact that we now know that there are opportunities for cardiologists to be a little bit in the OB world and obstetricians to be a little bit in the cardiologist world. I think where I would like to start, and where I think the emphasis really should be, is in empowering your patients. So I think a large part of it is, I think, need to do a better job counseling our patients on their risk for pregnancy. And in particular, if you have pre-existing cardiovascular disease, the importance of preconception counseling and pregnancy planning. And that cannot occur, I think, if we as cardiologists don't have the conversation with our patients about pregnancy risk. And I can appreciate that, getting into the nuances might be challenging for someone who is primarily trained as a cardiologist. But what I am sort of suggesting here is that, when you have a patient who is in your clinic, in a clinic visit, who could potentially get pregnant or maybe pursuing pregnancy, to just open the conversation with them and say, hey, you have pre-existing cardiovascular disease. For you, pregnancy planning and preconception planning is really important. Have you ever thought about that? And that just opens the door and in some ways plants the seed for the patient, because the patient might not have realized that that was even a thing to talk about, if that makes sense. I think the other thing that is also important to contextualize the importance of advocating for our patients and allowing and empowering them is that women are having children a little later, and cardiovascular disease is showing up earlier. Cardiovascular disease and risk factors for cardiovascular disease is showing up earlier. So really the likelihood of a patient crossing your clinic who falls into this category is not going to be uncommon. Here at UT Southwestern, we have the privilege of rotating or caring for patients at Parkland, which is our safety net hospital here in Dallas County. And certainly for that patient population, we have a high-risk cardio-obstetrics clinic there in Parkland. And for that patient population, I think the thing that has struck me the most when I care for them is how important it is that we do a better job educating them and just talking with them about their risk for pregnancy and planning future pregnancies. Because I don't think that we kind of as a community do a good enough job with that. So that's before pregnancy. I think after pregnancy, certainly people with pre-existing cardiovascular conditions who have had teratogenic medications held, for example, those need to be resumed. But the bigger conversation that needs to be had is going to be, we've gotten you through pregnancy. What are the thoughts for another pregnancy? Pregnancy planning is kind of a continuous, ongoing thing. So I think to summarize everything, the biggest thing that we can do, I think, as cardiologists in supporting this particular group of patients is opening the door to the conversation, letting them know that a pregnancy for them could be high risk and that we need to be proactive and to plan and think about it if they at all want to pursue pregnancy.
Thank you, Dr. Mauricio, for sharing all those important insights. I'll definitely take those points back to the clinic when I see patients in terms of thinking about preconception counseling for them. And I think another important aspect, as we brought up earlier in the episode that you had mentioned, Dr. Mauricio, this fourth trimester is really important for patient care, this postpartum period. And it's often where we lose patients, especially those with hypertensive disorders or cardiomyopathy. And Dr. DeFaria, how do you think about empowering these patients to advocate for themselves? And how, as a field, do we make sure that we are not losing these patients?
Well, thank you, Gurleen. This is such a critically important question and topic for us to talk a bit about the fourth trimester and how we, as a health system, as a healthcare community, remain very engaged with our patients to support them through this very difficult time in having a newborn and also caring for themselves as well. The postpartum period remains a high-risk period for many of our women, and that's something that I think many people may forget If we look at the distribution of adverse cardiovascular outcomes, maternal mortality, we see that up to a third of these adverse events occur in the postpartum period. I often will share with our fellows that, our job is not done after the baby is out. Sometimes we'll see everyone in the labor and delivery room with very high-risk mother, high-risk pregnancy. Finally, the baby comes out and there's a sigh of relief of high fives, we've made it through. We always have to remember that sometimes our highest risk times is still ahead of us in this postpartum period. There's so many hemodynamic changes that occur during that postpartum time that can continue to challenge the cardiovascular system. And if that cardiovascular system doesn't have normal reserve, we may see the development of heart failure in that postpartum period. So it's critically important that we don't lower our guard, if you will, in terms of our vigilance in screening for cardiovascular complications during this postpartum period, particularly for women who have hypertensive disorders or with cardiomyopathy or at risk for cardiomyopathy. We can probably think about 3 different buckets of opportunities for intervention. One is at our health systems level, one is at a larger, health policy level, and then most importantly at our patient education level. So from the health systems perspective, I think those on the line have mentioned some really critically important points. We have to ensure that we have purposeful and planned touch points with our patient, whether that is in a clinic, if they can make it to a clinic, or whether that is virtually versus with telemedicine options, or whether that's meeting them where they are in their community. And I think Dr. Hameed's comment about doulas in the community is a terrific one. So ensuring that those touch points are made, that there's continued, reiteration of why monitoring blood pressure or, their symptoms is so important in that postpartum period. And really utilizing that multidisciplinary team that Dr. Sharma mentioned of nurse navigators, of your pharmacists, of community supports to really help enable those touch points to happen and be effective in monitoring the postpartum care of a mother. Again, the use of telemedicine we found to be tremendously impactful, and some have published on, a nearly equivalent efficacy of blood pressure monitoring in the postpartum period, for example, via, virtual or telemedicine options. And so that's a terrific opportunity for us to really scale and leverage technology to our advantage in ensuring those touch points with our patients are made. That second big bucket around health policy and really insurance coverage, we suffer in the United States from what is such a highly fragmented insurance coverage system. And we know that certainly insurance coverage is critically important to ensuring that women have access to care and have better outcomes. With lack of insurance coverage in that postpartum period, we certainly see higher rates of adverse cardiovascular outcomes. So the expansion of, postpartum insurance coverage through that, first year postpartum really is one of the critical components for ensuring that our patients, have better outcomes. And then, of course, we can have all of the local health systems measures in place and we can have great policies and coverage. But if our patients aren't partnering with us and really sort of understand why it's important to have these follow-up appointments and to take care of themselves in the postpartum period, these efforts would be lost. So partnering with our patients, educating them early. Our education around postpartum care actually starts in the first visit, in their preconception counseling visit, or in that first visit when you meet someone early during their pregnancy, to emphasize early on in that pregnancy how critically important it is for us to make space and connect in that postpartum period, because the risks extend, far after the baby is born.
Thank you so much for that. And I really love the emphasis on the 4th trimester. I'm in the cardiac intensive care unit right now as the fellow. And we even just earlier today had a woman come in 10 weeks postpartum and ended up having SCAD. So Dr. Sharma, turning it over to you, what are your strategies to empower your patients, especially those navigating new diagnoses in the peripartum period?
That's a great question. And I think it's a really important question to look at this as a critical time window in a person's life. I, really appreciate all the comments from Dr. Mauricio, Dr. Hameed, Dr. DeFaria on the importance of the continuity of care and making sure our patients have the appropriate team around them, even after they have delivered and perhaps into a transition from the delivery to home. I think one of the things that I have seen a lot is the burden of a new diagnosis and grappling with a new diagnosis that they could have. So there is an important sort of phase of recognition that this is a new reality. Whether that reality is in perpetuity or is a short-term reality for them, that remains to be seen. But it is a very difficult time in a person's life. Many times they are not anticipating a new diagnosis. So the importance of sort of reiterating in a very calm, collected, evidence-based manner, but also the point that my colleagues have made, trying to create a system around them where there is a support structure, whether that is care through evidence-based, EMR-based, scalable technologies, making it very patient-centered, whether it's support through community health workers, doulas, or nurse navigation, which become bridges and the ties between the health system and home or the community where the patient lives. Whether it is providing extra, care in areas that are not traditionally considered a cardiac problem. And one of those things that I strongly recommend our cardio-OB clinicians to think about is psychological health during this time frame. Psychological health and behavioral health risk factors are the underlying major risk factor for adverse pregnancy outcomes and maternal morbidity and mortality in the US. They continue to rise. And when you're grappling with a baby in the NICU or a preterm baby trying to breastfeed, trying to recognize that you have a new diagnosis with probably a slew of different tests and medications that you didn't think you would be on, there is an underlying component of anxiety, which is understandable. And recognizing that that is a critical time where people can have postpartum depression for the first time and have anxiety for the first time. So recognizing other things that have a connection with the cardiovascular outcomes and providing care in those areas, for example, behavioral health therapy, or making sure there's a psychotherapy if the patients have been taking off their medications for chronic behavioral health, psychological health conditions, then reinstating them to provide them an extra cushion or layer of support. But also providing a long-term view of where life is going and where care is going and what care could be. I think this comes with building relationships with these patients, which are beyond even 3 months, 3 to 6 months, 12 months and beyond. I think creating that continuity of long-term care with the patient, really scaling it based on what the patient's problem is exceptionally important. And I can't stress the importance of a multi-layer of communication, having a really two-way communication. Oftentimes clinicians tend to be very short-staffed and they have a finite amount of time with their patients. A lot of times patients with this new peripartum diagnosis have layers of different types of care that they need, whether it is seeing a lactation consultant, whether it is seeing a genetic counselor, whether it's a behavioral health therapist. So having that source of connection between all of these care coordinates, I think, is very important, and that helps making the patient be empowered that there is a one hub and a spoke model for their care. And I honestly believe that hub lies in either primary care or in preventive cardiology.
Thank you, Dr. Sharma, for bringing up the importance of psychological health for our patients. And in cardiology, and even more so in cardio-OB, we're taking care of patients at such a vulnerable time in their lives and making sure they have the layers of emotional support to deal with these new life-altering diagnoses, like you mentioned, is so important. And I think overall, it's an exciting time for the field to see what innovations and system-level changes can be done to really improve the care for our patients. And with that, I want to transition to the last part of our discussion tonight, which is about looking ahead to the future of the field. So Dr. Sharma and Dr. Hameed, from your perspectives, from both the cardiology as well as the obstetrics perspective, what innovations or system-level changes would you like to see in cardio-obstetrics over the next 5 years? Dr. Hameed, we'll start off with you.
Wonderful. This is a great question. And I think I'm going to go over a couple of things from the system level. First, I think, as Dr. DeFaria mentioned earlier, the congenital heart disease patients, understanding the value of transitions of care, particularly from pediatrics to adult medicine. discussion of reproductive risk and contraception in adolescents, even before they ask the question. In recent years, as cardio-OB has emerged and more cardiologists are cognizant of the need for contraception, I'm often pleasantly surprised that our adult congenital heart disease folks have prescribed contraception, or they have talked about pregnancy, even though this is a patient who's not necessarily actively seeking pregnancy. So this part needs to be the standard of care. I would like to see this as part of the pediatric care as they transition over to the adult care. Secondly, to make a sustainable change, we need to embed cardio-OB education curriculum for our trainees, for the residents, and for the fellows. And I would like to see formal cardio-OB programs at all regional centers that take care of high-risk patients, patients with pulmonary hypertension, congenitals, and so on. Not only that, I also advocate for focused cardio-OB fellowship for both cardiology and maternal fetal medicine trainees. Those are the two system-level changes that I would definitely like to see. And then from the innovation perspective, our group has been working on developing a measure for cardiovascular risk assessment, and I advocate for universal cardiovascular risk assessment. And this is for all comers in pregnancy, not only for patients with pre-existing cardiovascular, but anybody who's pregnant. Just like we do screen pregnant patients for urinary tract infections and for hypertension, we should be doing cardiovascular risk assessment. And again, in pregnancy and postpartum period, because these patients who are considered high risk, they need appropriate long-term follow-up. And this would also include patients with adverse pregnancy outcomes. These are patients with preterm delivery, placental issues, hypertensive disorders of pregnancy. That's one. And then one of the biggest challenges in cardio-obstetrics when it comes to improving maternal mortality is the fact that a large proportion of patients actually may develop cardiomyopathy, which may not be in the usual pregnancy or the postpartum period. By the time they present, they may not be going to the obstetrician. They may be going to an emergency room for their care. So again, pregnancy history, when they delivered, and you cannot connect the dots between cardiomyopathy unless we know that there was a recent pregnancy. And now this is a patient who is coming in with shortness of breath. So again, important that we have the index of suspicion and we routinely screen patients for cardiovascular disease.
That's a great answer, Dr. Hameed. I have to say that's a super thoughtful and exceptionally well-rounded answer. A couple of things that I do think that are both system level and innovation level solutions for optimizing care for our patients is in the transitions, as Dr. Hameed mentioned. One is, when we are trying to care for pregnant patients with existing cardiac disease or suboptimal cardiovascular care antenatally, it is kind of already too late. Primarily because many of these cardiovascular risk factors have been going on for quite some time. They are difficult to be optimized, but I really believe in seeing an integrated care delivery model where, we've got integrated care delivery in heart failure. We have it in post-shock recovery of these patients. Why have we not thought about an integrated care delivery model in preconception or antenatal timeframe? Dr. Hameed mentioned, there are obviously the existing cardiac disease patients that really need cardiovascular risk assessment, but then trying to make sure that this care is integrated in such a way that if you flag this patient either preconceptionally or very early antenatally, they are sent to primary care, internal medicine, or cardiovascular clinician to have that conversation very early on, provided a roadmap of how pregnancy can be optimized and the risk factors can be optimized, whether that's managing their obesity, managing their hypertension, whether it's managing their diet and exercise, whether that's managing other cardiovascular comorbidities. And the other system level of problem that I see is that the handoff between OB and cardiology or even primary care is not optimal in many situations. And it's quite clunky, and there's no systematic, organized way to ensure that the onus is not on the patient. This is a pregnant patient or a postpartum patient that has a new diagnosis, perhaps in many cases, is battling with patients with the baby in the NICU in many cases, has a slew of tests that have been ordered has behavioral health, logical health, because they're grappling with a new diagnosis. And yet we don't have a systematic way of saying, well, we're going to take this one extra step away from you where you don't have to call and make this appointment, and we'll do it for you in such a way that you don't slip through the crack. I think we have got to do better in trying to make sure that we ensure that the patients are seen very early on by the transitional clinician once they're not OB patients anymore, or whether it's primary care or cardiovascular care. One of the things that we've been working on in our health system is an EPIC-based, EMR-based OPA, which is basically an optimal prompt where if a patient has been flagged in the EPIC system as having a cardiovascular diagnosis or having a new diagnosis of a hypertensive disorder or pregnancy, the clinician cannot post the chart unless they have made a direct referral to Cardio-Obstetrics. If we can implement something like that, which is scalable and obviously changeable based on the health system and what we can actually cure, and recognizing that on the back end, you should have the ability of the cardiovascular clinicians or the referring clinicians to absorb the patients that come through. But creating a system where the onus is not on the patient, but it is electronically mandated through a best practices advisory for the clinician saying, you really should consider making this appointment now before this patient is discharged and providing that information to the patient on a discharge paper.
Thank you, Dr. Sharma and Dr. Hameed, for those comments. I think you've both highlighted how imperative it is truly for patients, if we are trying to place them at the center of their care, that I think we've all agreed upon is the most important part of all of this, how important it is to really make those transitions of care, as well as the interdisciplinary nature of the care, as seamless as possible and taking that burden off of them. So thank you for those comments. Dr. Mauricio, we know that both cardiovascular disease and obstetric complications are a burden that are not equally shared among all of our patients, whether that's based on race, ethnicity, socioeconomic status, etc. From your perspective, what's one thing, I know there are of course many things, but what would you say is one thing we should be doing better to make cardio-obstetric care more equitable?
Thanks, Anna. That's a great question. You're exactly right. But there's not just one thing we could be doing to make cardio B care more equitable. And, since we brought up the topic, which is a super important one, I think we all can recognize that there are definitely policy level things that need to happen to support our young parents, not only to make sure they have access to medical care, insurance, etc., but also access to procedures that they might not need for their own health if pregnancy is high risk, but also very logical things, in my opinion, like paid parental leave and childcare support, et cetera, because all of those things are foundational to the cardio OB care for patients, right? Supporting the parents throughout this entire arc of what they're about to go through. I think so that it feels manageable and it feels like something that we can tackle. I think if I were to pick one thing that we could do to make cardio OB care more equitable, and this has certainly been hinted at by Dr. DeFaria, by Dr. Sharma, by Dr. Hameed, it is, I think, to think about bringing cardio OB care to our patients, and not in a physical sense, but also in an abstract sense. So what I mean by that, something that Dr. Sharma and Dr. Hameed have just discussed, I think we need to innovate when it comes to the delivery of care for this patient population. If you're specifically thinking about that 4th trimester postpartum period, it is so incredibly challenging to care for yourself if you're also caring for a newborn. I can speak to that from personal experience. It is just so hard. So I think, as Dr. Sharma had brought up, expecting that patient to make their appointments and to go here and to go there. And, that's just so much on top of what you're already doing, on top of recovering from pregnancy, right? So some of the things that we've already discussed in this conversation, telehealth appointments, virtual appointments, et cetera. At Parkland, we have a van that actually goes out to certain zip codes and brings care to the patient. Honestly, things like that, in my opinion, should kind of move out of the innovation realm and honestly be accepted as almost standard of care and what we should be doing. because this is a unique time for the young parents, right? Like you have more appointments for your newborn in that postpartum period than you do for yourself, even if you have high risk cardiovascular disease. And I think we need to recognize that we should probably be bringing the care to the mother versus expecting her to always come out to us. So, one, meeting the patient physically where they are, but two, also just kind of meeting them in an indirect sense where they are. And that goes back to empowering the patient, as we've discussed previously as well, opening up that conversation and telling them, hey, if you are considering pregnancy, this will be a high risk one. I want you to feel empowered to talk about that no matter who your care provider ends up being in the future, because I think we all also recognize that while cardio-obstetrics is now definitely a recognized field and cardio-OB teams are growing, it's still not as omnipresent as we would want for it to be. So it might be that our high-risk cardiac patient is going to probably interface with maybe primary care at the ER, and you have that one visit with them that you saw them at that one time, so really empowering them so that they can advocate for themselves. And part of that is also making sure that we are doing a good job educating other providers in cardiology and obstetrics, but also kind of everywhere about this patient population. One of the kind of obvious things that I can think about is that, I would love for all people to always take a pregnancy history, because I think that there's just so much that comes, so much that you learn from a patient about their cardiac risk if you take a pregnancy history. So informing our primary care colleagues, our ER colleagues, our pediatrician colleagues about what they could be asking this patient population, just so that the onus of it isn't only on the patient and isn't only on cardio-obstetrics teams that unfortunately are not at all centers.
Thank you, Dr. Mercier, for sharing your perspective about the importance of policy level changes and also the importance of bringing cardio-OB care to the patient and really understanding the barriers that our patients are facing day to day, whether that's getting to their appointments, getting their meds, and everything else that's going on in their busy lives in this time period. And earlier, Dr. Hameed mentioned that one system level change she'd like to see is incorporating cardio-OB education and training programs, including at the residency and fellowship levels. So, Dr. DeFaria, if you were building a cardio-OB program from scratch in the current era, what would be essential? How do we ensure that OB and cardiology trainees are prepared to care for this complex patient population?
Sure. Thank you. That is a fantastic question. And there is much to think about in building a cardio OB program. At Mass General, we had been sort of operating in separate silos, and around 2010 or 11 really came together and joined forces to have more of a formalized cardiovascular disease and pregnancy program. And we followed a co-directorship model there between the adult congenital heart disease program and our women's heart health program, with close collaboration with our maternal fetal medicine group. And with that, many lessons learned along the way. I think the importance of communicating across our disciplines is so incredibly important. And in order to do that, you have to actually set aside and carve out time to do that. We've had a monthly meeting where all of the members of our team, both in cardiology and MFM and nursing and anesthesia and our extended multidisciplinary group, come together and we talk about all of our patients who are actively pregnant with cardiac disease, review possible complications that could have come up, and what is our contingency plan, in the event that something did occur, and ensure that all the appropriate appointments and follow-up touch points are made and solidified at that time. So that, time investment that we all have really committed to has been an important piece in ensuring that we really can hash out all of the considerations that will allow us to provide individualized care to our particular patient. So from the clinical perspective, those monthly meetings have been critically important. From the outpatient perspective, as Dr. Mauricio mentioned, our patients have many appointments. And so we really try to be as patient-centered in collaborating and aligning those appointments. Some centers have co-localized clinic where everyone comes together. We try to align those appointments, on the same day at the same time to minimize that burden. And on the inpatient side, we've really worked to formalize what is a rapid triage. When, patients who are sick with a cardiac condition, whether it's a brand new diagnosis of pregnancy or they've had a known underlying cardiac condition, our ED staff, as well as others in the hospital, know who to call and who is on call to help best manage that patient. So thinking about both the inpatient workflow and the outpatient workflow has been an important component of ensuring that we have that immediate availability for care. And of course, aside from the important clinical considerations in the clinical program, there's the importance of the research mission and trying to learn new things and create new knowledge. And, as programs grow, if they have the resources and funding and opportunity to invest time in research, that is so critically needed right now in this field for us to be able to do better. Your question around training, this is also so central to elevating our ability to address cardiovascular conditions in pregnancy. Understanding the fundamentals of pregnancy management for cardiologists is not just for those who are interested or think this field is cool. It really is for every single cardiologist. Whether you're, interested in pursuing more expertise in the field or not, it truly is for every single cardiologist to feel comfortable with some of the fundamental concepts in cardio-obstetrics. And so this really puts an important responsibility on training directors to think about, how are we training the next generation? Are they getting the exposure to these patients in a way that they'll start to feel comfortable in managing them? Have they had the appropriate kind of, lectures and didactics and that sort of thing to give them the foundation and the groundwork? And then for those who are interested in pursuing higher levels of, expertise, sort of what are those pathways moving forward? Several of us on the line are working on a fundamental educational series really aimed towards this, educating all general cardiology trainees in the country and also educating our MFM trainees as well, and doing that in a collaborative educational platform so that we feel that they're learning in an environment, our trainees are learning in an environment where they really see that close collaboration, not only in the clinical care, but in their education as well too. So, many components to building a comprehensive cardio-OB program, from the clinical pieces to the research mission to the educational and the advocacy, of course. But every program starts somewhere. And I think if, you are at a program where there are a few people or experts in this area, know that trainees should feel empowered. You're often the people who bring us all together and remind us that we can talk across lines and sort of create these collaborations. So feel empowered that you can be someone who can help to facilitate the development and the growth of a cardio-OB program in your local institution.
Thank you so much for those comments. As a cardiology trainee myself, who is extremely interested in cardio-obstetrics and women's heart health at large, that's really exciting to hear about some of the formalization of that interdisciplinary care, both as an inpatient and an outpatient. And we are all very much looking forward, I can speak for myself and Gurleen, of course, to see this educational curriculum be developed and deployed to programs all over. Before we wrap up this, what has been an illuminating discussion, I would love if we could go around with our one final question for each of you, the age-old favorite CardioNerds question. What makes your heart flutter about cardio-OB? Dr. Hameed, maybe we can start with you.
My heart flutters to see the field of cardio-OB thriving, and I'm incredibly excited to see trainees like yourself seeking cardio-obstetrics and absorbing it.
That's awesome. And Dr. Sharma, what about you?
Likewise, it's really the trainees. It's really amazing to see how excited people are about this field, and I'm also very deeply excited and honored that there are now medical journals that recognize cardio-OB as a mainstream area of publications. We have Journal of American College of Cardiology Advances, a journal which has a very strong focus for women's health and cardio-OB, not to mention that the main JACC. But I've also seen so many other journals such as Circulation, HAPC, many others that have super high impact factor, really published mainstream pregnancy, heart disease, or postpartum health papers, which is really, really exciting to become mainstream in cardiology, and really exciting because that's a great way of dissemination of knowledge.
Yes, absolutely. Dr. Mauricio, what about you?
Yeah, I think to build on what's already been said, definitely the growth in cardio-OB, that it's been recognized, the innovation in the field, and honestly, the enthusiasm of the people who are in cardio-OB. I think we're a pretty enthusiastic bunch because we love it a lot and we kind of want everyone to love it as much as we do. I think also something that really resonates with us is it's such a unique, such a wonderfully fulfilling patient population to take care of. All of our patients are, but in particular, the cardio-OB patient population, because it's kind of like a high risk, very nervous time for the patient. So I want to just tell a quick patient story because I think it really illustrates this very well. to something that Dr. Hameed has brought up also earlier in this episode. I had a patient who was diagnosed with HCM in her first trimester of pregnancy. So in addition to kind of grappling with that diagnosis and having that diagnosis for the rest of her life, she's also a G1. So this was her first pregnancy. And throughout her pregnancy, she was appropriately so worried, is this my HCM acting up? Is this a normal pregnancy outcome? I don't know. So I saw her fairly frequently during her pregnancy. And I see all my patients for postpartum visits. And when she came to her 6-week postpartum visit, she brought her kiddo with her, which is not uncommon for my cardio-OB patients. And it was just really lovely to see her on the other side of pregnancy with her baby. And she was just so thankful for the cardiac, sort of the anchor from the cardiology perspective through this time period in her life. I told her frequently, don't worry about that. I'll worry about that for you. You'll be okay. We'll get you through this. And I think in addition to everything that's already been mentioned, I think caring for this patient population is so special and honestly such a privilege.
Thank you, Dr. Mauricio. And what about you, Dr. DeFaria? What makes your heart flutter about cardio-OB?
Sure. Gosh, there are so many things that I could say, but I will say that the gratification and knowing you've been part of a family's journey is really such an honor. And I love seeing healthy and happy moms, healthy and happy babies, even better if they're euvolemic in the postpartum period. But it truly is just such a privilege to be part of their care and be part of that journey. And then to continue to follow them later over years and watch their, children grow. I saw a patient just yesterday whose daughter is now 13, and I just can't believe it. I feel like she was just born. So I will also say what has been wonderful, and this has been said as well, but I have to reiterate the enthusiasm, the interest, the excitement that our trainees have, and the recognition of how incredibly important this field is, the education around women's health and pregnancy. I'm so thrilled we're in a place where we recognize how critical it is for cardiologists to understand, this field, understand pregnancy, and really recognize that we can do better and care for our patients. So thank you so much for pulling all of us together.
Thank you. This has been such a powerful conversation. Thank you, Drs. Mauricio, Dr. Hameed, Dr. DeFaria, and Dr. Sharma for sharing your time and insights with us. It's truly been a privilege to learn from such a fantastic panel of experts in the field, and we're so thankful for everything all of you do for the field, from a clinical perspective to a research perspective to advocacy and education. I've loved all the passion that you've instilled into this discussion tonight, so thank you really so much.
Thank you so much for tuning into this CardioNerds episode. The audio editing for this episode was performed by me, Grace Chu. I'm an intern in the CardioNerds Academy, House Jones, and medical student at Thomas Jefferson University. Check out the episode page for show notes and references. If you found this episode or show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episode. And now, my friends, it's time to make like an S2 and split.